Welcome to chapter 2. This chapter will start to talk about healthcare data. And boy, to say this is critical. This has played a role and continues to play a bigger role as we start to capture more and more data in healthcare. But this will start to talk a little bit about more. This chapter focuses a little more on the patient side, but I'm going to add some kind of tones to it that start to talk about what's going on the consumer side as well, which is starting to become more and more important. So we'll start to talk about, the data, the definition of it in terms of healthcare, the information sources, and where we use some of it. And then, of course, the importance of quality, if you will. Okay. It's important to weave into this the notion of what we call PHI, protected health information. And this is a slippery topic, if you will, but we cannot be too careful as good stewards of other people's healthcare data in knowing what is protected and what isn't. And full disclosure, I do a decent amount of audits and stuff in the HIPAA space, and I frankly see a lot of violations here around inappropriate use of protected health information, and even up a level, what is protected health information. That said, what I will add to this is most of the time when I find infractions here, it is not intentional. It's not malicious at all. It's people just, quite frankly, didn't know that you couldn't do that. And probably, an example I can give you is a colleague of mine was working at one of the COVID vaccine clinics some time ago. And he posted a picture of all of the people in kind of the waiting area. After you get your vaccine, you have to wait 20 minutes to be sure there's no reaction. So he posts a picture of this, and there's all these people's faces. And I said, you really need to take this picture down. I said, you've just violated the HIPAA rights of every person in this photo. You can't post pictures of people. And he said, well, I thought it was a good thing. And I said, yeah, it is, but you can't share that. So not intentional, wasn't trying to hurt anybody, but is truly a violation. So the text will talk about EMR versus EHR. For the most part, we will use those terms interchangeably. There are some slight nuances, but for the greater good, we'll just kind of consider those virtually one and the same. What is different, however, is a PHR, personal health record. And this is something that I, as the individual, the patient, if you will, the recipient of care, is the keeper of. I have inputs into this. I have a significant amount of control here. Okay. We'll also talk about the scope of care, what we call the episode of care, or episodic. Okay. I fell and broke my arm. I went to the ER, right? Whereas the continuum of care is more of, I have an established relationship with the primary care provider. I go to this individual annually for a physical. I go for well care. I go for sick care, and all of the above. And then population health, where I look at a specific population. Okay, this could be the long-term care population. This could be, like I mentioned in an earlier lecture, the K through 12 population. It could be the middle-aged working mom population. And now that what kind of COVID has taught us is how the virus can impact different ethnic groups. So there's been some targeted efforts to look a little more closely at given populations. So for example, we have seen that in some cases, the African American and Hispanic population is been hit harder with COVID than some of the other ethnic groups. So we have to look very carefully at populations, and that's getting more and more emphasis over the years. So why patient records? Why do we have them? A lot of reasons, as you can see here. Some of the reasons, things that, obviously caring for the patient, communicating back and forth, some legal documentation, the billing, the reimbursement. And what we're getting better at is the research, if you will, the research, the quality management, the data analytics of, we've been capturing data, as I mentioned in an earlier lecture, in some type of capacity specific to healthcare electronically since the very early 80s. Now we've got to figure out, how do we extract that data to get value from it? This lists out some of the components of the medical record. Some of these might be very obvious, some of them not so much, but basically it's your combined elements that makes up a patient chart, okay? And you can see them all here, but a couple to kind of call out: the problem list. And this is just that. It's a list of, there's a big movement to move away from calling it the problem list. But like, for example, if you have high blood pressure, you would see hypertensive on the problem list. If you're diabetic, that would be on the problem list. More of your chronic conditions, but then also some of your episodic stuff, if you will, right? So if suddenly you have a sinus infection, the notion is you don't have a sinus infection forever, right? But I still put that on the problem list. And then I can put an end to that as well and say, okay, the sinus infection is no more, right? Talked a little bit about accountable care. Okay, so moving from episodic to population health, looking at that bigger community, we've done a historically pretty poor job of this, if we're being honest. Again, COVID has given a little more attention to this, but we just don't do as good a job as we can. We rely some on HIT, we need to rely more, okay? So some of those specific components also detailed your accounting, your billing within the record. I want to be sure that you have valid insurance coverage, who those third-party payers are, and if the third-party payers don't cover, who's going to pick up the rest of the tab, which is usually you, the patient. Okay. This is kind of a snapshot. This is an Epic system. All the EHR providers have something very similar, but this is your basic, what we call the demographic screen within Epic. And as you can see, it's very what we call tabular in nature. So the notion is you can see the users on the first tab, the contact information, and then they would move through those tabs as they fill each one out. This particular tab would likely be completed by a registration clerk. This would be the first point of contact with the patient where we verify the very basics of information, but also incredibly important information, right? Who are you? What is your gender? What is your date of birth? What is your address? Who's going to pay for this? Do you have an advance directive? All of those things. Then we move to the problem list. And as I said earlier, this is one of those things that kind of stays with you forever, but hopefully this is usually entered in by the nurse that triages you or the doctor that sees you. Okay, so as you can see, it lists out what that diagnosis is, and as you can see, you can bring this to resolution, right? So let's say you seek treatment, you're diagnosed with high cholesterol, and you adopt a healthy diet and exercise regimen. You could see that fall off and you no longer be diagnosed with that. So you would then resolve that condition. The progress note, this is where your physician typically will put in some narrative text. This has been an interesting dichotomy in healthcare IT, if you will, because physicians in the paper world would handwrite this out, the actual progress note. We move to an electronic environment, they type it out. They get very accustomed to this. What we have done, the major vendors, Epic, Cerner, I'm not 100% sure on the others, but I know Epic and Cerner have reached a point where they can actually extract out keywords, codify it, and use that for data mining. Otherwise, this becomes very challenging to look at these and look at narrative text and look at this from a big data standpoint. In fact, it's nearly impossible if you don't codify keywords. This is an example of a lab report. My only criticism of this is it does show up in color in Epic. I don't know why they brought in the content to not be color, but this is incredibly critical when you're looking at a lab report. As you see here, if you look at the top two entries, the hemoglobin and hematocrit, I will caveat and say I am very much not a laboratory person, but you can derive enough here where you can see in that column, it shows you what the range is. So hemoglobin has a range of 13.5 to 17.5. And what it tells us is the value that was recorded, it looks like 3 years ago, was 13.0. That is below the acceptable reference range. You also see that with hematocrit. In the live Epic system, this would appear most likely in red. And the idea is we want this to just jump off the page to the provider so that they know, hey, this could be something of significance that I might need to look at. Okay. The other thing we do is, if you remember back when you looked on the problem list, it would actually have codes next to those problems. That corresponds to a ICD-10 code or a CPT code. And the idea is this gives us a codified reason as to why you're seeking treatment. Years ago, we moved from ICD-9 to ICD-10. And the way it was described to me was ICD-9 at best would tell us what you were dying of. ICD-10 will actually tell us why you seek care. We went from ICD-9 having roughly 40,000 codes to ICD-10 having 200 and roughly 50,000 codes. And I had a clinician that was far more intelligent on the topic explain this to me. She said, Dave, under ICD-9, if you broke your arm, there was one code. I know just enough about anatomy to know there's 3 major bones in your arm. And is that really going to cover it? Under the new ICD-10 terminology, there were 40 different codes for a broken arm. So you can see how we get into that next level of granularity, if you will, which is incredibly helpful. So we got all this data. What on earth are we going to do with it? Well, hopefully we're going to do some data analysis. So we've got all this data. What we have found is it has not been stored in the cleanest fashion. It hasn't been maintained well. And then getting access to it continues to be a problem. And this is where healthcare continues to be the outlier, if you will, in its own way, shape, or form, and that we constantly worry about invasion of privacy and are we being good stewards of data by looking at the data that's contained within these EHR systems to do big data analysis, okay? This is kind of a good comparison of small versus big, right? So in the old days, it was in a file cabinet, it was very static, it was hard to get to, versus big data. They compare it to a conveyor belt, which I think is an interesting analogy, but we've got a lot of it. We got a lot of different types. It moves very quickly, and we can do a bunch of different things with it as soon as we can figure that out. I'm personally very excited to get my hands on some of this COVID treatment data. As I mentioned earlier, we're starting to see some inequities in terms of how different ethnic groups survived through COVID, how it's impacted them. We've seen data, different disparities around how it's impacted different age groups, how it's impacted people with different, with what we refer to as comorbidities. Okay, so health conditions that can have a negative impact on your health. So things like hypertension, diabetes, obesity, it'll all be very interesting data, and we'll be looking at this for decades to come. And if you look back in history, you've probably seen some of the parallels through COVID. We've talked about Spanish flu that was, about 100 years ago. We're still trying to analyze what happened with the Spanish flu to tell us what's going to happen with COVID, which fairly accurate, not so much accurate in a lot of other ways. So again, small data, some of those statistics, utilization, performance at the individual provider patient level. Big data is I want to look at the institution. I want to look across the county. I want to look across the city, the state, and even the country and start to make some inferences, start to predict what may or may not happen. Again, focus on quality. All right, do we have constant quality? Is it reliable? And should we really be actioning on that data? We'll talk more about it, but a great example of quality data is the data that we're getting from the personal wearable devices, right? More people now than ever are wearing Fitbits, Garmin watches, Apple watches, you name it, and collecting a lot of data about their personal health. Is it accurate for us to trust this data? Maybe not, but it can shine a light on some details around a person's health. So it's worthwhile, and we're kind of keeping a close eye on that. One organization that plays a pretty big role in the oversight of data quality, accuracy, and governance is AHIMA, okay, the American Health Information Management Association, a special interest group that is very passionate about this. In fact, there are a couple, if you will, ordained degrees out of that institution, that organization, an RHIT or an RHIA credential, which basically means you've gone through either a 2 or 4 year degree track and been trained extensively on some of these components on the screen, culminated by taking a competency exam at the end. Several people you'll see, like I said, have that credential that work with health information of an RHIA or RHIT. Another organization as well that kind of focuses on the same thing, less popular, but the text mentions it, so it's worthwhile to show here. So kind of in summary, we talked about the importance of data, where we're going, what's ahead. Again, we've still got a long ways to go. Like I said, COVID has really highlighted a lot of these concerns, but we're still facing an uphill battle here. And I'm hopeful that in the next decade, we start to make some significant strides in this space. So that concludes chapter 2, and please let me know if you have any questions.